I'll start recording also. One second.
Okay.
Bhavya, just approve the request for the recording. Yeah.
We are live now.
Okay. Recording has started. All right. Okay, let's start. Good afternoon, everyone. As you're all aware, OCI has 4 special interest groups on Facebook, which are dispensing optometry, clinical optometry, binocular vision, and low vision. So every month we have one session in each group. And today we are having our first session in clinical optometry special interest group. For this, I would like to invite our today's speaker, Dr. Noor, and panelist, Dr. Rashima and Ms. Jinal. Dr. Noor Zaman is an optometry graduate from Zamia Hamdard University, New Delhi, and he has completed his Masters of Optometry from Lotus College of Optometry. He has earned his PhD degree from Chitkara University, Chandigarh. Dr. Noor is a fellow of IICL, fellow of BCLA, certified orthokeratologist and specialty contact lens practitioner. He is also a joint secretary and fellowship coordinator for ASCO, India. Currently, he is associated with Sankara Eye Foundation as a head of department for Sankara College of Optometry in Punjab. He is quite active on YouTube for skill-based clinical videos for patient and eye care practitioners through his channel Optometry Reels. We also have today Dr. Ashima and Ms. Jinal with us as a panelist. Dr. Ashima has completed her BSc Optometry, MPhil and PhD from Birla Institute of Technology and Science. She currently leads the occupational optometry services of Sankara Netralaya, and she, along with her team, provides eye care to employees and industries and workers in the unorganized sector. She is primarily involved in occupational eye care for the deserving group of workers among the unorganized sector through the CSR support by the various NGOs. She is also an active researcher and has presented her research works at various national and international conferences and received prestigious awards like Young Scientist Award, Golden Jubilee Award from Indian Association of Occupational Health, and the Best Guest Report Award from the Optometry Counselor of India. She is also a proud recipient of Endeavour Executive Fellowship Australia and a competitive grant from the Glaucoma Foundation. Ms. Jinal has completed her Bachelor's of Optometry and Masters of Optometry from Lotus College of Optometry, Mumbai. She is a fellow of IICL with 16 years of clinical, hospital, and core academic and retail experience in optometry. She currently runs her private practice in Mumbai named Personalized Optometry and Eyewear. She is also a visiting faculty at Lotus College of Optometry. She is a Rosque co-educator and a consultant optometrist with Fortis Hospital. So today's session will be a little different than usual because it will be more interactive session. We are going to take cases and followed by each case, we'll be taking a attendees questions and a panel discussion also. So if you have any questions, please mention them in the comment section. So without wasting any further time, I would like to invite Dr. Noor, Dr. Rashima and Jinal for this discussion today. Over to you, Dr. Noor. Welcome.
Thank you. Thank you. Thank you, everyone. And thank you, OCI, for giving me the opportunity to present this wonderful topic, which is the importance of communication skill in the history taking. So we all know that how important is the history taking. So let me share my screen. Is my screen visible? And so history taking, which is very, very important, and effective communication in the history taking is equally important. So how we go about when we say communication skills, or when we say effective communications, it is actually the ability of the professional, or whether it's an optometrist or any healthcare provider, they should be effectively and compassionately interact with the patients and their families and other members of the healthcare. So what it means? It means through your history taking, through your communication, you should be able to build a strong and a trust among the patient as well as the families of the patients. So thus it ensures the effective and the high quality healthcare among the your fraternity. So that is why the effective communication has to be there, and this all can be achieved by following this certain steps, that we have to be a good listener, we have to be very effective, and we should be paying attention to what patients is trying to communicate. So this we can do by being attentive about the patient's concerns and their needs. While communications, while history taking, we should be empathetic, we should be compassionate towards the patient's problem. We should understand the patient's emotions, their anxiety, their fear, and their needs. And this all should be in a clear and the simple language. We should not be using the medical jargon, like many a times people may use that, do you have strabismus, or do you have a cardiovascular disease? So these all things should be avoided during history taking. Use a simple term, be specific about that area where you are doing the examination. For example, if you are in the rural area, so you should be certain about their terminology, what they understand, what they use. So it should not be like, I'll tell you one example during my internship days. So we were taking a history and I asked a patient that, do you have sugar? Patient says, yes, I have. So the next question was, ki kitna? So she was like, कि घर में तो बहुत है sugar. So she could not understand that I am talking of the diabetes. So we have to be very careful that whether whatever we are talking, whether the patient is understanding that effectively or not. Okay, it should be, sometimes we may have to use the non-verbal communications also. Through our body language, through our facial expression and the gesture, it should show empathy. It should show that the patient is being heard and understood. And this helps us, or this will help the patient to open up clearly in a better way, and that will help us in a better diagnosis and getting the more relevant information. And this will ensure building a trust between us as well as the patient. We have to be also careful about the cultural sensitivity. Like many a times, few community, few cultures demand certain specific way of treatment. So we should be careful in those areas also, in those cultural sensitivity. We should be sensitive enough. Also, the type of information that we are sharing during our communications, whether during history taking or during a course of the treatment, what information are we providing? It should be true. We should be honest and accurate. We should not be providing as per the assumption. Until unless we are not sure about the diagnosis, we should not be coming to a clear-cut diagnosis, because this may hamper the treatment procedures. This may hamper the patient's psychology towards the treatment that patient is going to take that. So our information should be accurate and relevant to the case, relevant to the conditions. And we should be aware and let patient aware about the risk as well as the benefits of the process, to ensure that we are also taking the informed consent with the help of with our information that we are sharing. any conflicts or should be resolved with understanding. It should be resolved with peacefully. Sometimes conditions can happen that patient or the attender or the family may not agree with the certain procedures. Maybe sometimes they may be a conflict. So that should be dealt with the calmness. That should be dealt with the in a proper way. You should not be yelling at the patient. You should not be equally abusive to the patients. So be careful about your professionalism. Be careful that your identity is not an individual. You are representing a profession when you are dealing with the patient. And this effective communications will also ensure effective time management. Like you will have a burden of seeing certain number of cases each day or during that day. So you should manage your time in that, because there will be a pressure on you from the senior, there will be pressure on you from the management, or of course you personally. So you should be using very accurate and the effective communications so that you should finish and you should clear the files on time. Also, the interpersonal professional relationship or the communication should be very, very strong. Sometimes it happens that when we are dealing with the patients, or especially during our school days, our internship or the third year, sometimes we may not understand certain things, or we may get stuck on something. You may require the help of your senior. So use appropriate language, use appropriate body language and the gestures, so that the patient should not come to know that they are being seen by somebody who is not competent. So your competency or incompetency should not be reflected during that time. Sometimes you may agree on this. I'm sure we have our panelists. They may also experience, they might also comment on that, because I have seen during my during my teaching days, sometimes especially during the low vision history taking, some students they may get stuck on certain things, and they when somebody asks that, or when their colleagues come, they end up saying that कि हम try तो कर रहे हैं, but ये पता नहीं क्यों नहीं पढ़ रहा. So these things should be avoided. Okay, so because you have to understand that patient may be visually impaired, but they may not be the hearing impaired. So you have to maintain certain dignity. You have to be careful on certain things. So these are the few areas where you can use your communication skills effective to handle the history or handle the patients, because the history taking or the initial process when you are interacting with the patients, interacting with the parents, you should gather enough information that is relevant and that is useful for the diagnosis. So overall, this history taking helps a lot in our clinical practice. So I have tried to put few cases for everyone first to understand that what happens when we are doing a history. We are taking the information from the patient. So this is the first case. Patient had shown an interest of going to for the refractive surgery. For the LASIK, patient has come. He was 32-year male, software engineer. Chief complaints was the blurring of vision and difficulty seeing distance object. He also had these symptoms for the last 5 years, and it has been progressing. There was no history of the ocular trauma or surgeries. There was no known systemic or the medical history, and he's also not on any medication. So the ocular history and history was the diminished of the vision for the last 5 years, blurring of vision, no history of any medications, no systemic illness. no history of the allergy. He has never worn contact lenses, and his occupation demands 8 to 10 hours of the near work or the intermediate work on the computer. And his visual acuity was uncorrected acuity was 618 and 612 in the right and the left eye respectively, which showed an improvement with the pinhole. So seeing this history, can we make a conclusion? Can we draw a conclusion that this patient can be can go under the refractive surgery? Is this information sufficient enough to give a conclusion or to help patient go through the refractive surgery? If you ask me, I may say there are certain information which is lacking. We should understand few more things, because if you see the history of glasses, which was not mentioned, whether the patient is using a glass or not, whether the refractive error which patient has was stable or not. Few other things from the panelists, if you can point out, if you can say that what all things we should be looking towards the refractive surgeries, if somebody has.
Yeah, thanks, Dr. Noor. And Harshada, can we just see whether is there any post in the live? What does audience say? Is this patient suitable for refractive surgery? Do we need to ask any more questions from the patients? So these two answers, can we have some comments? We'll wait for a minute and look at the comments.
Yes, I'm checking 1 second.
Dr. Noor has presented this case. This kind of cases come to us often, right? LASIK is actually a trendy surgeries. They don't want glasses. And when patient comes and report to you, what are the things we should be inquiring from the patients? This is what we wanted to discuss with this case. So if you have any points, you can put it on to the chat box.
Give a minute, Rashima. Usually there's a small delay in Facebook. I think we'll just continue.
Yeah.
Okay.
So
Yeah, one person is saying the refractive surgery is possible depending on the corneal thickness. So yeah,
Right.
correct. So
Corneal health.
That will be a little later, maybe once we go into evaluation.
yeah,
In
and
part
people
of
are
history.
yes, other people are saying that history of contact lenses use is also important. Also, what is the initial refractive error was there, and since when the refractive error is stable,
Excellent.
or so these are the comments.
Excellent.
Family
You're
history
all, you're all with us then.
Yeah. Yeah, I think in refractive error,
But-
also the family history of myopia plays a very important role in terms of whether it's progressive or stable.
correct. And also the expectation of the patients and the motivation. So that is also equally important. Whether what is the expectations of the patient, whether they require a 6 by happy vision or they want to attain 6 by 6 visual acuity. So that is also equally important for us to
Yes.
counsel during counseling.
If you
History-
ask this patient's occupation is he's a software engineer, so you know about what is his requirements on a daily basis, and his refractive error was not listed here, so you don't know whether he's myopic or myopic astigmat. So that was not listed, and also about how many years he has been using glasses.
Correct.
And how is the refractive stability? Does parents have myopia? Was there any other surgeries done to him? And any medications which could actually hamper the refractive surgeries post-care assessment. And somebody has listed about the corneal health condition, mainly the corneal thickness. Stability of refraction is listed. And as Noor was mentioning, what is the expectation from the patient? Because even if you give
Yeah.
6/6, the patient might not be happy if the expectations are not satisfied. Okay, so you should also be informing the patients about the challenges with refractive surgeries and the complications, so that the patient is aware of what is the plus and minus with the spectacles and with refractive surgeries. So in that way, we can actually send the patient very happy.
Just a point here in terms of occupation, you know, what you rightly mentioned, a person who is driving at night or who is traveling a lot
Yeah.
needs to be aware of the glare issues and everything.
So along with this, the assessment of pupil size and things also
Yes.
matters before the patient goes in for refractive surgery. Even any corneal haze, previous history of injury, there is some corneal haze that can actually hamper on the refractive surgeries. There can be a the refractive error comes back, right? So it might not be the same. So you need to explain to them all these factors.
And since we are talking about refractive surgery, just a case which came a couple of days back, there was a history of refractive surgery which was done. But during the marriage, things were hidden and all. And then suddenly when you are trying to check the retina, you can see a myopic fundus and where cornea is also not very happy. And then you probe and you need to find out when was the refractive surgery done. I mean, it's not we are, you know, assessing the patient for refractive surgery. It's the history which is done already. So a lot of people are not open to share the right history to, you know, to probe and get that out is also important.
Yeah, that's right.
Correct.
Because we need that during cataract surgery also while
Right.
doing IOL calculations.
Exactly.
So getting that history is important. Yes.
So that they're the need of effective communications. So if we lack in that, we may miss certain information, and that can patient has to bear or during the course of the treatment or after a few years they may have to face the consequences. So thank you everyone for understanding what should be the pre-refractive surgery history taking. We got a lot more information than through their experiences. When patient surgeries are done, so post-refractive surgeries also we have to be very careful. We should be knowing that what we should ask the patient, what should we see. So we have to look for the visual symptoms. We have to look for the pain and the discomfort the patient is going, whether the process or the treatment which has happened is healing effectively or not. Look for the medications that were suggested that patient is instilling, using on a right way, on a right time. Certain activities may ask to restrict, so that needs to be ensured that they are not doing those things. Again, the satisfaction of the patients in terms of the outcome of the refractive surgeries, in terms of visual acuity, and the post-op complications. So these are few important things that we as a primary healthcare provider, when we are doing a history or taking a history, we should be understanding and we should be taking account. Another case, which is a pediatric case, a 6-year-old female child, first grade in the school. The parents has a major concern about her making eyes small, squinting of her eyes to see the objects, and they have noticed it through the right eye. So further history was taken, and it was found out that the birth and the development history, that she was full term without any complications during pregnancy or during delivery. Our developmental milestones were also appropriate as per the age, like crawling and the walking and the talking. There was no significant family history of the eye disorders or the visual problems. She has not undergone any previous eye examination or the vision screen. So she had come for the first time. No known systemic and the medical history, and she was not on any kind of medications. So this was the history which was taken, and based on that, if I ask you to make a conclusion that where this history is taking you. What can you guess about any tentative diagnosis? So I'm talking of the tentative because history taking will not give you a confirmed diagnosis. You have to do certain analysis, certain tests to confirm your diagnosis. But with this, can you understand and can you help me out what this case could have been?
Attendees, could you please comment in the comment box?
Okay, so just for you to understand that this case was basically a amblyopia case, a case of the amblyopia. So because I know this, I'm telling you, but with this, if you see this, patient has the problem as per the parent in the right eye. So it could be unilateral. There was no, again, the history is again incomplete because she has not been using any glasses because she has come for the first time. So we don't know what is the refractive status of the eye. Okay. On further investigation, we found out that the patient has the amblyopia. Again, to confirm the amblyopia, we have to look for the all other aspects of the eye. We have to look all anterior as well as the posterior segments to ensure that the loss of the vision or the amblyopia or the lazy eye is not because, I mean, this problem is not because of any pathological or any other problems. So this is how we deal in a pediatric. And pediatric history itself is a huge. We need to understand few important things. Okay, so for example, when you are dealing any pediatric patients, you need to develop a rapport. Your clinic or the where you are working should be child friendly. You should keep certain toys which could attract, which could develop a healthy atmosphere for the patients. You should not be scaring your patient with your environment, with your surrounding, with your clinic. Gather background information from the parents, because not all time the children will open up or will be accurate. The parents are the ideal and the ideal persons who can tell you the history in a better way. Look for the chief complaints. What is the major concern of the patient or the parents? Look for the birth and the developmental history. So it could be prenatal, like any complications or the problems during pregnancies, any history of any uh, toxicity or any kind of other complications. During delivery also, look for what kind of birth it was, a delivery it was a C-section or the normal delivery. What was the gestation period? Developmental history is again equally important, like their crawling, their talking, their speech, whether that was the age appropriate or it was a delayed. You can also take informations if they have regarding the ABGAR score, which is 5 points that we see. One is the appearance of the child. Second is the pulse rate. Third is the this what is that G? G is the
Grimace.
grimace, correct. The this grimace, the sensitivity. A is again the activity of the child. R is the respiratory respiration. So each points has the two points. The total of the 10 points it is calculated on, and the value above say 7 or 7, 8, 9 are considered to be better for the child. Anything lesser than that is a critical. So if you have, of the parents have this information, that is also equally important for you to understand. Also ask for any kind of complications after delivery, whether the child was kept in intubations, any oxygen deprivations. So all these things will help you in certain diagnosis. Family history, again, the medical history, history of the vision, about the presenting visual acuity, history of the glasses is important. Eye-related symptoms like redness, any kind of squinting in the eyes. So these all things should be also making count. Visual habits, like how patient is, I mean, how much the patient is using his time on the digital devices or the screen or televisions. Okay, so these are again important, especially if the school going children, where they sit in the classrooms, what are their postures during their study or during their near work. So again, the school performance, like what is their grade, how they're performing the schools, any history of the ocular injuries, any eye care routine, like about the hygienes, about their, I mean, history of rubbing their eyes. So these all things is very, very important when we are doing a pediatric history. So we should be seeing a pediatric very carefully, because to getting the information from the pediatric is again a challenging. You require a help from the parents or the guardians to take the accurate information. Anything which anybody wants to add, or do we have any questions?
Not on the FP. Dr. Ashima, would you like to comment on this?
Yeah, there were
Yeah.
few comments here that when you're evaluating a child, it is important that the parents are also near to the child so that the child is more comfortable. And if you are evaluating a female child, it's better you also have another optometrist, a female optometrist around, so that you're very sure of, and you give more assurance to the parents also. And as Dr. Noor was stressing upon, establishing a good rapport with the child, so that don't rush upon a case. Mainly in a pediatric cases, don't rush upon on the case. It is not important that you finish the case. It is important that you gather maximum information from the case. That is very important. So establish a good rapport, then the child will actually cooperate with you for all the assessments. All right. So if you spend the extra 5 minutes in talking to the child and making the child comfortable, then all other procedures will get over very soon. Okay. So have that in your mind when you're going to be in studentship or just going to practice. Have these things in your mind when you're handling a child. Okay.
Just a comment, Rashima. I think especially for children, if you just observe them when you're talking to the parent, as you're talking to the parent, just keep observing the child. That itself gives you a lot of information.
Absolutely.
And, as long as you don't touch the child, like be in a rush, like you said, no? Because usually for students, if it's a busy OPD, they just want to finish.
Yeah.
But I think when you go to practice, it is very different. You have to be very patient when it is pediatric cases, because if you rush, then they don't. So I actually have a patient who refuses to see Ajay. She only asks for me for whatever reason. We don't know. She just won't even say hi to him. She's been coming for almost like now 6 months. Even if he behaves friendly, she just doesn't. I mean, we don't know, like we can't explain children's behavior, right? So sometimes she just refuses, and the parent gets very upset saying that, how can you be so rude? And I'm like saying, well, you're only making the situation worse, because I need to get my job done. So please don't upset her, So I think they're very difficult lot to deal with. So I think just observing them, not rushing to touch them and stuff like that. And then once they get comfortable, then maybe, because in our profession, you'll have to touch the face some way or the other, either for the slit lamp or something like that. Okay. So, and that time, if they're not comfortable, then it really, beats the reason why you're actually there.
Yeah.
So this is just a small comment. And the one more reason, why I put the comment on the chat box is this is something I'm just going to share, not taking any specific names. We had a very bad experience maybe a year and a half ago where one of our optoms, female optoms, she was examining a teenage boy, and then he acted very funny with her. And then he came out and then he just walked off from the clinic. And, you know, and the optom was literally like shivering when we went inside. So that's why I said it's very important to have an attender, especially. And after that, we really make sure that somebody is there in the examination room. It need not happen to the optom. It can be the other way around also. You know, that the optom can also misbehave with the patient. I'm not saying it is there. I'm just saying that both ways, we need to make people comfortable. That's all.
That's very true, very true. Many of the incidents have happened here too. So it is important that we have another person other than the patient and the examiner inside the room when we are especially evaluating children.
And a CCTV could also help.
Yeah, absolutely, Gina. Especially in private practice and all of that, it's important.
Absolutely, yeah.
And for the optometrist, when we are dealing with the pediatric, we have to be applying all the knowledge also, because see, not all pediatrics are of same age. So we have to be very specific about what type of chart we should be using, what procedures are we going to do on the pediatric. That also helps a lot in getting the information or getting the diagnosis more confirm and accurate.
Every time we wanted our children to come back for the follow-up, right? So if they are not going to be comfortable on the first visit, they're not going to come back to your follow-up. So it's important that you establish a good rapport, be very friendly with the child. So the child says, as Lakshmi ma'am was mentioning, wanted to come back to Lakshmi ji only, right? Likewise, they wanted to specify that I want to go to this doctor only for my glasses.
Long-term relationship, absolutely, you know, so. And involving the child in the entire history is very, very important. I mean, not sidelining the child, because now the little kid also needs importance.
Correct. Similar things we also experience, because in our college we have the interns who are rotated. So from one department to other, when we do a therapy, the child comes back and he asks for the specific interns or specific persons where that Didi is, where that Bhaiya is. So again, that a good thing for any interns that anybody is asking for them. But again, everybody should be very familiar with the pediatric, and they should be able to handle the pediatrics effectively. So moving forward without wasting, because again, this is something which is interesting to every one of us, history taking, the communications, pediatric history especially. So I'll moving forward to the another important case. You see this. So he was 52-year-old accountant, a male, who had came to the clinic with his concern about the vision. He reports that he has been experiencing a gradual decline in the vision over the past 5 years, and primarily noticing a difficulty in seeing the objects clearly, especially in the low lighting condition. He mentions that his eyes feel uncomfortable occasionally, but he also attributes it to be age-related changes. So this was his first information that we gathered. And further, when we look for the other history, we found few key points, which was the history of myopia. He had been using the glasses. Again, he had a low myop. He had no history of any injuries of the surgery. His father was diagnosed with the glaucoma at the age of 65 and has significant, vision loss due to this condition. He leads a sedentary lifestyle due to his desktop jobs. He admits that spending prolonged hours working on the computer. So based on this, I believe that we can come to a conclusion. This can help us getting to a conclusion that perhaps this could be a case of a glaucoma. Why? Because if you see the patient aging, 52 years of age was one condition. Second, history of myopia. Patient also complains that his low lighting conditions was the another a problem that he has been experiencing. Has a family history of glaucoma and also a sedentary lifestyle. So the risk factor of the glaucoma, major risk factor of the glaucoma has been are being seen over here. So again, with this history, we can make a tentative diagnosis, but again, I would say that this cannot be very, very accurate. You need to do the further investigations to find out the type of glaucoma, if patient has this glaucoma, or to find out any other associated problems along with this, or to rule out the glaucoma, you need to do a proper or comprehensive eye examination. Could be related to their IOP, could be related to the angle, could be the CD ratios, optic nerve. You may require certain equipments like thelmoscopes, perimeter, GDX, or OCT to confirm the diagnosis of the glaucoma. Any things which you people want to add and you want to make?
We just wanted to highlight that anybody who is above 40 years of age, always have in mind there is a risk for glaucoma in age as age progresses. So always people above 40 years of age inquire details on glaucoma too, right? Like in their family history, do anyone in their family is continuously using of eye drops? Or nowadays people are aware of this problem called glaucoma. It's not that they don't know the term. Some people say that, oh, there is eye pressure, so my father was using drops for continuously. So you know that, yes, there is a family history. So always above 40 years, have an eye, just evaluate their intraocular pressures, at least one disc photograph, so that you know whether the person is at risk or not. Okay. This particular patient also responded that he is having difficulty in low lights and also had frequent uncomfortableness with the eyes, like repeated redness and pain was also been reported, which is one of the symptoms of glaucoma. Right?
And in terms of glaucoma, in terms of medication, what the patient is using, whether he was using in past and he has stopped it on its own, then the pressures are under control. So, that also needs to be noted.
Yeah, like how they say for hypertension,
Yeah.
there was pressure, so I was taking for a while and then it was
Yes.
controlled, so I stopped it. Likewise, they should not be
Right.
stopping on their own.
Right. True.
And again, optometrist's role is very huge, because if you see a lot of optometrists go to for the community eye care, especially during our college days, or now on the occasion of World Sight Day. OCI is aiming for such a huge number. So people will be going for the screening. So please be careful, not looking only for the refractive error or the presbyopia, though the patient or the people may have also a glaucoma. So we are going to be a key, our role is going to be a key in predicting or finding out the glaucoma, or detecting. Early detection is, we all know that what is very crucial and important. So let's hope that we are going to save at least few patients or the few eyes during this event, which is going to happen.
Right.
So another case, which was a geriatric case, a 70-year-old retired teacher who visited a clinic due to her concern about the vision. She reports that she has been experiencing a gradual decline in her vision over the past few years, especially noticing difficulties in reading the books and the newspaper. She mentioned that she frequently needs to hold a reading material at the arm's length to see clearly. Now, with this history, many of us will come to a certain conclusion that this lady might be having certain problems. So if somebody would have shown me for the first time, I would have said that the patient is a presbyope. So let's see what could be the other things. On further investigation, we found that the lady had a mild myopia since her teenage and has been wearing the glasses for the distance. cataract surgery was done in the left eye 3 years back. She had the history of hypertension as well as type 2 diabetes for the last 10 years, and she was under medications, and perhaps it was also under control. She leads an active lifestyle, participates in community activities, spent a lot of time with the children, reading, gardening, engaging in the crossword puzzles was her day-to-day activities. What it means that she has been very active. Her requirements for the vision is good. Now, with the initial history, we can assume that patient was could be a presbyope. Again, with the further understanding on the history, we assume that okay, the right eye might also have developed a cataract. So second diagnosis could be a cataract. Third, I believe that since she was hypertensive as well as diabetic, so retinopathy could also have occurred, or some signs of retinopathy could have been reasons for the discomfort in the patient. So along with the one diagnosis, especially in the geriatric, patient may have multiple problems, and we have to again see pediatric cases, geriatric populations very carefully, because their demands for the vision is very, very crucial, because those are people who are retired. They like to sit at the home, spend their leisure time effectively. So this was about the geriatric. Any points anybody wants to add up to this?
Geriatric history again goes, where they are able to manage their basic things independently. It kind of goes again with low vision in terms of diabetic retinopathy or anything to do with hypertensive retinopathy. So counseling and involving somebody of the family is very important, because, dependency and stimulating the issue what the patient is going through also becomes an important part.
True.
And again, with the physical health dwindling and the eye health also not in the right shape, psychologically it's a tough game to crack.
Right.
Yeah, and
Like-
also, continue.
They are the two extremes. We had looked at the pediatrics, and the geriatrics also needs the same care as pediatrics. Okay,
Absolutely.
most of the time they will be like, they may not be able to sit in the chair properly and things. They might need somebody to talk to them. So here again, rushing is not the case. You need to actually talk to them, convince them they should be happy coming to you. And sometimes, no, the geriatric people, they wanted to say that I wanted my eyes checked by this particular optometrist because I feel more comfortable. He's like my son, he's like my daughter. I wanted to meet him. Those kind of things will just make them comfortable with you, right? So these two extremes need special care. So I just wanted to highlight on that.
They require a lot of patience, and
Yes,
and also
yes,
we
yes.
have to understand their need for the vision. I mean, what is their demands, what they expect through us. So we have to be very specific on that. So we may not aim 6x6, but at least we should be providing a visual acuity or the vision which is sufficient enough to lead their happy life, day-to-day activities.
And just one point here, during history itself, a lot of times I have seen in a hospital setup where a patient's relative is taking them in the morning for one opinion, and because they have found out something, they are going for a second opinion on the very same day, and the pupils are dilated. And then they come to us, and during an examination, a lot of times they don't mention as a second opinion. So, when a person is having a specific question, we need to just gauge from that conversation that he has already visited somewhere else. And I have seen an intern once, putting the observation as fixed dilated pupil. So it was not a fixed dilated pupil. It was a dilated pharmacological pupil where, we could go in a very different tangent and finding out the pathological aspects of pupil dilation, and also just finding out a very simple thing like, oh, it's just a first time visit or it's a second opinion when we observe a fixed dilated pupil.
Yeah, that's right. And I feel it's more important to stress on the symptoms also, because people will say only I can see black spots, but are they moving black spots or are they fixed black spots? So that can help us in further investigations also. So if it's a fixed, then we have to rule out for the ARMD or something like that, or floater. So we have to, being an optometrist, so we should stress and get more from the symptoms also, I feel. Yeah.
Right. When we see people with diabetes or hypertension, it is important that we think about the changes which would happen in future also, and counsel the patient that if you see anything like this, be aware that there is a possibility of diabetic retinopathy changes, and do come and visit to us. Or you can even give them a home amsler to document things,
Yeah.
look at the progression and things.
I mean, looking at a very holistic way of life instead of just focusing on eyes.
Right, right.
Okay, thank you. We have another case, which is a special able child, 8-year-old who live with her parents and a younger sister. She came to eye hospital for eye examination due to concern about her vision and the eye health. She had a history of nystagmus, strabismus, and she occasionally squint or tilt her head to see the objects. So again, for any special kid, especially able kid, we need to understand, or we need to gather a lot more information. Again, this is something which we should be specialized, not everybody is specialized. So birth and visual and the development history is equally important. So we found out that she began sitting independently around 10 months and started walking with support at 2 years. She is not yet able to walk without assistant, which is showed a delayed milestone. Speech development is again delayed. She primarily communicates through the gesture and the simple words. Social and economical, social or emotional development. She enjoys social interactions and affectionate with her family members. However, she may have difficulties making eye contact during conversation. So these were the few basic information that we gathered for this child. And for you all to understand, this was a case of the Down syndrome. So along with this information, we, as we saw in the history taking in the initially, we have a list of information that we need to gather from the child, whether it's a pediatric, geriatric, or even the special child. Everything needs to be, every information needs to be taken care or gathered. So what we found in this, that the patient has a delayed milestone, patient has the problem in the vision, patient has a problem in the eyes, she had a nystagmus, she had decreased visual acuity, and however, her social and emotional development was within normal limit. So this was a case of the special child. Anybody wants to add few points to this?
Anything in terms of special case or anything in terms of congenital deformities, history of consanguinity is very important to ask. So asking in a way that is not, attacking a parent is very important.
Yeah, that's what. The one question is like, how do we deal with such questions, the cultural sensitive questions with the patient? Like suppose in RP cases or these specially able child, we have to ask the consanguinity history. So
Yes.
what could be the probing question, or how do you make them open up about these things? Because most of the time patients and even the practitioners feel awkward about this type of questions.
I mean, I very simply start with, if both the couples are there, both the partners are there, that are you married, are you having any relation between you all in terms of, family relationship? And also it a lot to do with the ethnicity. I mean, certain caste and people have this thing where we know that, consanguinity is present predominantly. So as you know, with the name, you can question accordingly. So
And
they very
we-
openly, at least what I have seen till now, they very openly say, yeah, they are my first cousins or second cousins. So if they don't understand it directly, you can talk as cousins. So are you distant cousins to each other?
Yeah,
I don't feel anything to be hesitated as
Yes,
a examiner.
absolutely.
We have
exactly.
to-
You don't need to be
Absolutely.
hesitant on asking this question. If you feel that there is a rigidness from the parent side, you can actually explain it to them why this question is important
Yes.
for us to know. So in that case, they will be able to actually give back the answers. So most of them give the answers directly. They say that,
Yes.
yes, he's my cousin, or things
Yes.
like that. But if they are hesitant, and if you feel that they are not comfortable in disclosing that, you can explain it to them why it is important. And as I'm addressing the child, it is important that I know about the consanguinity, but it could actually be, the risk could be even higher. So if you explain it to them, they will be, because they have come for their child, right? Or for their own self in case of like RP and things.
And when we are talking about differently abled children, it's also important to know if they are doing any occupational therapy or doing any remedial things along with it, where there are a lot of visual perceptual issues also, and just putting it on history will help for further ongoing consulting.
Hmm. Hmm. And in case of a special child or differently able child, look at their visual search behavior. How is it and things? See where, I mean, before even you bombard into doing a procedure, just see, grossly understand what is their visual things, so that you can actually start from there on. So talking to the child, talking to the parent itself, you just, on the side, you just look at the child so that you know where to start your assessment for the child. That's very important here.
Correct. And
And
again,
level of intelligence also matters, like certain Down children are extremely intelligent. So it's very easy for you to communicate with them. And
Yeah,
they'll be
and you should know what is the special attraction, catch on to that, and then
exactly,
start with
yes.
it.
and again, I believe that again, mastering the special child is again a specialty. So
Yeah,
we
your
should
listening
be,
skills should be absolutely high when you're tackling a special child. You
and
have to
one
be
has to
very,
be
very
good
patient.
observer. I mean, see, the right from the patients enter to your clinic, you should be keen in observing their behavior. I think a lot of work will be solved, or the questions, answers you will get by observing the kid itself.
Yeah, the 10 steps which Dr. Noor was listing at the first, I think all these 5 cases have captured those 10 steps. And the 5th special child case needs all the things, right? So,
Yes.
Yeah, that's right. Yes.
And leaving this, just we were talking about the geriatric case or a middle-aged person, it's very important to understand the vocational history, because they may have very specific need-based issues which you need to address, and write down in the patient words, in the history, that this is what the issue is, and then address it accordingly. The vocational history also becomes important when it's the earning person of the family. Yeah.
Again, Saranya ma'am mentioned something, ask the questions as a matter of fact, that especially if you notice one parent is blaming the other for the problem. So there's something that happens in the consanguinity.
Yes.
right.
So this was the 5 cases we tried gathering the information from all different aspects when we see a patients in our clinic. So it could be somebody come for the cosmetic purpose, like a refractive surgery, could be a pediatric, geriatric, some pathological conditions, or I mean, neurological conditions like a glaucoma or a special kid. So we tried gathering all the aspects of the history taking and the effective communication, because we know that history taking and a right communications helps us or supports for the accurate diagnosis. It gives us the tailor-made or personalized treatment, because like based on the patient's complaint, based on the patient's concerns, chief complaints. We need to plan our treatment. It also build a trust between the patient and the examiner. When you are good with the communications, it gives a patient empowerment. Patients feel they are connected to you. The patients feel that they are being examined with the right people, right person, and that helps. That also adds to the compliance. When the patients feel they are part of that treatment processes, they will follow what you are saying or what treatment you are suggesting. So this all will help us getting a better outcomes, and ultimately it will give you a sense of satisfaction and it will build your practice as any professional. So I believe that effective communication is the fundamental aspects of the high quality optometry practice. We all should follow this practice. We all should be very, very efficient and good with the communication and the history taking.
Thank you so much. Yes, rightly said, communication skills are very important in our profession. As Saranya ma'am is there, I would like to ask her to if she has any inputs or anything.
Harshita, thank you. I've been listening and it's been a wonderful session. Greatly well summed up, Noor, and great inputs from Rashima and Jainal. I've just been adding on as they've been talking here in the chat. So they've been doing brilliantly. So thank you so much. Thanks, Harshita.
Thank you, Saranya.
Yeah.
Thank you.
Yes, thank you for the wonderful session, Dr. Noor, Dr. Rashima, and Ms. Srinal. I'm sure lots of doubts has been addressed, especially for the students. Today only we completed 900 members for clinical optometry group. So congratulations to all the attendees and all the members of the group. We're looking forward more sessions coming up every month. So stay tuned. Thank you so much, guys. Thank you.
Thank you.
Thank you. Thank you, everyone.